Hello, I'm Luis from InHealth Advisors, and I'm here to ask you the question, what's your problem? Whether you're a newly minted physician or a seasoned healthcare CEO, we at InHealth are here to help you solve the biggest challenges in the business of healthcare in 5 minutes or less. So let's get started. Addressing social determinants of health, health related social needs, and health equity, these are all complex topics. So I wanted to try to find an image that would concisely tell the story and summarize the challenge. This figure from the Kaiser Family Foundation does a great job of doing that. The COVID-19 pandemic had a significant negative impact across all populations in the United States when it came to life expectancy. But the harms were especially concentrated in the American Indian Alaska Native population. From 2019 to 2021, life expectancy among this population decreased from around 72 years to 65 years. This illustrates what's at stake in terms of solving these challenges. No less complex a challenge is rewarding physicians and other providers for their efforts at addressing social determinants and health equity. We're often asked by clients where they can even begin to start with these challenges. This video will cover two effective strategies for incorporating provider compensation incentives to do just that. We'll conclude the video by covering some of the data sources that can help fuel effective incentives. There are two straightforward ways that we've seen physician compensation models incorporate incentives for addressing social determinants and health equity. The first way involves risk adjusting panel size and other work effort measures based on social risk factors. The second involves paying a quality bonus tied to improvement in these domains. Let's look at those in further detail now. We'll begin with risk adjustment. Many compensation models incorporate risk adjustment and apply it to work effort measures when it comes to determining provider compensation. For example, some compensation models pay providers based on their panel size, that is, the number of patients that they're treating, but they risk adjust the panel size based on clinical risk factors using systems like the hierarchical condition code dataset that's published by Medicare. Panel sizes can also be adjusted based on social risks. We'll cover this in a little more detail when we talk about data sources, but you can adjust panel size based on risk adjustment factors tied to social risk data measuring systems like the ICD-10 Z codes. Making this process easier moving forward is that Medicare is now reimbursing for the process of administering social determinant of health screens to gather the data necessary to perform this social risk adjustment. Let's take a look at an example of social risk scoring in action. The table that you see here presents the social risk score and corresponding risk adjustment factor that's used to calculate panel size for a given patient population. For example, the social risk score is based on the count of Z codes for that patient. So if a patient has a social risk score of 0, they'd count as 0.95 for the purpose of calculating the panel size for the provider. By contrast, if the social risk score is 6 or more, they'd count as 1.5 for the purpose of calculating panel size. The second table that you see shows a couple examples of patient risk scores and the corresponding risk adjustment factor. As you can see from this table, despite the fact that there are 7 patients, based on the social risk scores of those patients, they're counting as 8 for the purpose of calculating panel size. With compensation for this provider being tied to panel size, you'll see that the social risk adjustment system allows for higher compensation for treating a patient population that have greater health related social needs. Risk adjustment works well for primary care and other impaneled specialties, but not so well for surgeons and other doctors that are procedure based. For those providers, a quality bonus tied to improvement in outcomes for an underserved population works well. Quality bonuses are not a new concept and therefore less complicated to explain. A couple of approaches can be used for structuring quality bonuses to improve outcomes for underserved populations. The first approach involves looking at stratified performance measures. The process of stratification involves looking at performance for a specific subset of a population. In this case, we'd want to look at an underserved population. For example, using the common quality benchmark of managing HbA1c levels for diabetic patients, if a group were able to meet or exceed the 75th percentile benchmark, they could earn a bonus of, say, $5,000. The stratification approach involves looking at the benchmark that's specific to the subpopulation. In this case, we can consider an example of dual eligible Medicare Medicaid patients. So the provider would earn the bonus if they exceed or meet the 75th percentile benchmark specifically reported for the population of Medicare and Medicaid dual eligibles. The second approach for quality bonuses involves applying a multiplier to the bonus for meeting goals for underserved populations. For example, take a quality bonus of $3,000 that's paid for a provider that's able to reduce the readmission rate for their patient population to 5% or lower. If that provider were able to reach that threshold under 5% for both the overall patient population as well as the underserved patient population in question, for example, looking at Medicare and Medicaid dual eligible patients, they could earn a multiplier of, say, 2 times of the bonus amount. Therefore, if they hit both those thresholds, their bonus that they would earn would be $6,000. With those compensation incentives in mind, let's talk a little bit about the data that's needed to fuel them. We can break that down into two categories. The first involves looking at data that reports social risk factors, and the second involves common areas where stratified information is available for, say, performance measures. For the first bucket, looking at social risk factor data, there's a couple of key resources to familiarize yourself with. The first are the ICD-10 Z codes that I mentioned earlier. These codes track social determinants of health for patients, and as I mentioned, Medicare is reimbursing for screening for these codes. The second social risk factor data set is the Area Deprivation Index. This is a tool used by Medicare and increasingly other entities for tracking the degree of social need associated with a population by zip code or even census tract level. I provided a link to these resources in the description to this video. The second bucket of data pertains to the common points of stratification for populations for benchmarking purposes. The most common areas where we see stratification are on things like dual Medicare Medicaid eligibility status, patients that are eligible for the Part D low income subsidy, as well as other demographic factors like race, ethnicity, and educational attainment. As time goes by, we anticipate that more publicly available benchmarks will be published, stratified by these populations. For the time being, you can rely on your electronic health record systems to do the stratification and develop benchmarks internally within your own organization. Okay, so that took longer than 5 minutes. But given the importance of the topic, I felt the extra time was warranted. So let's review what we learned today. First, we talked about two potential ways that you can structure compensation incentives to help address social needs as well as health equity. The first compensation incentive structure involved performing social risk adjustment using a variety of data sources for the purpose of adjusting compensation higher or lower based on the underlying social risk characteristics of the population treated by the provider. The second compensation structure involved a quality bonus that was tied to improving performance for an underserved population. Within the quality bonus, we looked at how you can take a structure that looks at stratified benchmarks based on patient characteristics, as well as a multiplier approach based on achieving certain quality benchmark thresholds for both the overall patient population and an underserved patient subpopulation. We concluded then by talking about some of the common data sources that are used for social risk adjustment and tracking social determinants of health, as well as looking at some of the common areas where patient populations are stratified based on their characteristics for the purposes of targeting underserved populations. We hope that you found this video helpful. And as always, the experts at InHealth are ready and willing to answer any questions you might have about business challenges in healthcare. Reach out to us today. And hey, do me a favor. If you found this information helpful, please subscribe to our video channel. We appreciate it and hope you have a great day.